Board. Okay, we are doing the evening session of paramedic promotional exam prep. Tonight, we're going to go through the statewide treatment protocols. There is a ton to look at. So we're going to get right into it. Just put your name, if you wouldn't mind, your name in the chat with your number, just so I can read. And Benny, I know you were here in the morning, but it helps so that we know how much interest there is in more and more of these sessions. So just throw your name and your number in there. Full disclosure, I didn't have time to grab what's it called, the CEU for it, but you will definitely be credited for being here. Okay, let's get started. I am going to share my screen with everyone. If I can find the right button. There we go. Okay, you guys should be looking at the statewide treatment protocols. Okay, and once again, I will remind everyone that we are working off of 2025.1 protocols. They are changing. They will be changing in the next 3 months. I did actually look through all of the updates and changes, and there aren't a whole lot of changes, so you don't have to worry about, oh my God, I'm going to have to learn a whole bunch of new stuff if I go into the program. You won't. There are some. There's two big changes. One, we have, in addition to the postpartum hemorrhage, we'll be getting a new drug, but most of the stuff is language changes as well as stuff that was medical direction now is standing orders. So other than that, it's pretty similar. Let's strike it from the top: patient care. Now, I said to the day session, and I will say this to you guys as well. If you have not read through the entire 1.0 routine patient care, it is worth reading. There is some stuff buried in the patient care document, which actually impacts everything that we do, not the least of which is how we write trip sheets and how we access or how we medicate for IOs, which is nowhere else in the document. So if you haven't read it yet, I'm going to hit the highlights. I would recommend you go through it on your own at another time. Responding to the scene safety, proper PPE and BSI, you all should know already from doing it in your BLS role. But just be aware that per state regs, EMS should not walk anybody to the stretcher. Yes, I recognize that we do it, and often we do it appropriately. But if you walk it, unique circumstances and deviations from these protocols should be clearly described. So if your patient is ambulating and they want to, if it's not inappropriate, if it's not dangerous for the patient to walk, if the patient breaks his wrist, there's really no reason for you to have to carry him. That's just foolish. However, if they're dizzy or they're having chest pain and they want to walk, it's really on us to try and convince them that's not the wisest decision. Ultimately, people have agency. They are allowed to do what they want to do. If somebody does want to walk, make sure we're on either side of them. You already do that, but please document that in your patient care report. It takes on another level of risk when you get into the ALS arena, and now we are required to be monitoring their cardiac rhythm, and we are expected to know more about occult injury or illness. The other thing that you have to be aware of, it's the same BLS and ALS, but I know that we tend to be a little bit more liberal in our interpretation of this line: bring all necessary equipment to the patient. In order to function at your level of certification at the ALS level, that means you have to have a med box and a monitor with you. So be aware that is a requirement. If you get to the patient, they end up being ill, and you don't have your jump kit, your med box, your monitor, the state isn't going to accept Well, we had a really good BLS crew on scene and they didn't say we needed it. So just be aware of that as you move into your new role. If the patient has a valid MOST or comfort care, uh, you need to make sure that you can see it. You guys do termination and non-viables all the time. I would expect that is well within your wheelhouse. If you'd like me to go over it later, we can certainly hit that as we, go into the deeper protocols after the kind of general treatment area. But there are certain criteria that need to be in place for those things to be valid. So just bear that in mind. And also remember, at the ALS level, you're now the expert, right? So there's nowhere to turn to say, I'll keep ALS coming because they're going to make the decision. You are the ALS coming. So you're the one who's going to have to make those decisions. So it's better to start getting comfortable with that now. Patients who are minors cannot refuse treatment. We can talk a little bit about what constitutes a minor. I certainly hope you know that already. As a quick recall, anybody under the age of 17, under the age of 18, that is 17 years, 364 days, is technically a minor unless they are emancipated. Emancipation is they are married, they are a parent of a child or pregnant or believed to be pregnant, they are a member of the armed services, or they are head of household in a control of their own finances. If they prove to your satisfaction that that is the case, and you believe they have capacity, just like any other adult, they can then refuse. You cannot take a refusal over the phone because you don't know who's on the other line. And I had a long talk with Deputy Remus recently about this, where there was a bus accident and there were 6 kids, all nonverbal. The bus driver was injured, or not, it wasn't the bus driver, it was the person that the bus driver hit was injured, and none of those kids went to the hospital. And there were no, and they were all refusals. Well, how do you have a refusal for a nonverbal child without a parent on scene? So it can be very, very complex, these are things that we really have to be paying attention to. There is no regulatory lift assist anymore. You guys know this? This should not be new to you. There is no way for us to document lift assist. It's either a transport or it's a refusal. The only time that you can have not a refusal would be if you arrive, somebody's sleeping on a bench, and you say, "Hey, buddy," they wake up. No, I'm all set. I just was taking a nap. But that has to be documented in the narrative. And of course, if they have a bump on their head, if their speech is slurred, if they got into a fight, all of these have to be refusals. And at the ALS level, ignoring that becomes even more problematic. So one of the reasons why the ALS hate getting on scene, is because they recognize that if the person has any sign of illness or injury, they are at a higher expectation to evaluate. And they don't want to write these things any more than you guys want to write these things, or the BLS anyway. So just be aware that we really have to cross our I's, dot our T's, do cardiograms as standard of care. Cardiogram for us at the ALS level is another vital sign. So I know a lot of our medics are a little fast and loose with that, but that's really what gets them into trouble. The most clinical remediations that I see with the physicians are because the paramedics were dismissive of minor complaints and they didn't do a 12 lead. You can turf a lot of stuff. You've seen it. I know you guys have seen it out there. The patient doesn't have to be sick, but prove they're not sick before you turf it. So it's my goal, truly, truly my goal for the next generation of medics, that we get away from yeah, they're fine. Sick, not sick, they're fine, go to the hospital. We need to be a little bit more vigilant about taking care to do good assessments. Okay, if the patient's not transported, you need a refusal. You know that. So let's get into quick assessments. First thing you arrive on scene, once the scene is safe, you determine hemodynamic stability. That is your very basic assessment. That is primary survey, A, B, C, D, E. Everybody should be aware of that. You do that now. Any life threats, and this is where you do the 12 lead. So if you are at patient side and there is some reason why you want, for modesty reason, not to do a 12 lead, you don't want to do it in front of coworkers. You don't want to do it in the middle of the jetway. You don't want to do it in the middle of the restaurant. That's fine, but you should pull them aside on the stretcher. And frankly, it's easier if you put somebody on a stretcher and you put them in a 30-degree angle. It is much easier to get a 12 lead. Get them to a space of privacy or even the back of the ambulance as quickly as possible. Do a 12 lead and then determine, where you're going to go from there. Within your scope of practice, you should be obtaining a peripheral IV as standard operating procedure. If you're working somebody up at the ALS level, 80% of the time they should have access in place. You don't have to do it for every single patient, but we often dismiss it because, oh, we're so close to the hospital. Recognize in your statewide treatment protocols that part of our standard of care is IV access if possible. If you don't get IV access, write why you didn't get IV access. You take a look, you tied it off. Patient did not appear to have any IV access, longstanding IVDA, elderly with brittle skin, patient requested we defer. All of those things are perfectly good reasons, but write it down. Now, here's the caveat about getting an IO. We spoke a little bit about it at the day session. If you're putting in an intraosseous, this is a painful line for patients that have any marginal mentation. So if they're in cardiac arrest, you don't have to worry about it. But if they're not in cardiac arrest, you're putting in an IO because they're critically ill and you need to get access. You should be doing an anesthetic dose of lidocaine unless it is otherwise. Michelle, can you do me a favor? Can you just go on mute because you've got the radio on in the background and I don't, thank you very much. I just don't want somebody who's listening to this, tomorrow or the next day to have that in their ear. So, lidocaine as an anesthetic dose for numbing of the IO. Think of it like when you go to the dentist and they give you Novocaine. They don't give you a shot of Novocaine and then pull out the drill and start drilling. They walk away, let it sit for 5 or 10 minutes, and then come back. So obviously we are in a time-sensitive role where if we're putting in an IO, the patient is ill, but we really, really should try and give it 60 to 90 seconds at a minimum of dwell time. Just let that lidocaine sit and then flush it with a 10 ml bolus over 5 seconds. That will really numb them up and it'll go a long, long way to improving patient comfort. If you're doing it in a PD, then it's 1 mg per kg to a max of 20 milligrams. So that's an important anesthetic caveat to doing an IO. If you are working with a patient who's critically ill and they already have a PICC line, they have a lot of comorbid medical issues, and you cannot get a peripheral IV, it's recommended you try to get the peripheral IV first, but we will teach you in the didactic program how to access a PICC line. And then if you can't get a peripheral IV, don't spend 10 or 15 minutes trying. Just go right for the PICC line as long as you're trained. Don't do it until you get trained. Important to recognize that ventilation, we monitor ventilation both by end tidal and SpO2. And once you're in the more advanced realm, once you're in the paramedic realm, all of your patients should be on end tidal, whether it's nasal or it's more advanced airway, and you should be monitoring that and resuscitating your patient based on those numbers. Every single patient with an advanced airway is required to have quantitative recordable waveform capnography. That is a deal breaker. If you put in a tube, you must have end-tidal CO2. I said it to you when we went over the the exam, no trace, wrong place. That is the single gold standard to prove that we are in the right place. There have been many times where other agencies or other allied health professionals have accused us of not being in the trachea. And the way we counter that accusation, if you will, is by proving we have end tidal waveform capnography. That should be kept at 35 to 45 unless there are specific exceptions discussed with medical control. Okay, so 35 to 45 is your normal, and the only time you should be considering going down to 30 is if you've got a herniation. That's, medical control discussion and so on. Okay, every patient should be documented.
Kathy,
I know, yes, go
sorry to
ahead.
stop you.
That's
I
okay.
just wanted to get a clarification regarding the lidocaine administration.
Yep.
So we give it over the span of 2 minutes. Give the 10 milligram flush over the span of 5 seconds. Are you waiting another couple of minutes before we
No,
give
no,
treatment?
right. So the way it should go is it's 40 milligrams, which is, I believe now, there's a couple of different ways that the lidocaine comes. It'll sometimes come
Two,
in a
it was
10
like
cc
two
per
to four.
Right, right. So we now have, Jen had said our new preparation is 5 cc's is 100 mgs. So that's 2 cc's of fluid is 40 milligrams. So what you do is you take the 2 cc's, you inject the 2 cc's and let it sit because you're not going to spend 2 minutes pushing 2 cc's. You just push the 2 cc's and you let it sit. It's called dwell time. And then once it dwells in the cavern, the intraosseous cavern, for a minute and a half, then you take the 10 cc's of fluid and you push it over 5 seconds. And that flushes it all out. Okay. So when you initially start the IO, you are supposed to draw back, see that you get marrow, and then get a good push, get a good flush. You want to do that to start. Once you get a good flush, then you take the lidocaine and you anesthetize the site. Okay? Does that answer it? Okay, great, excellent. All right, we'll keep going. We come down to once you have your patient, vital signs, you have capnography connected up, you have the patient on the monitor, because this should be your setup, right? O2 IV monitor is how you kind of situate yourself, and then you go deep into your thorough assessment. Now, obviously, this happens concurrently. You don't put an IV and the 12 lead on before you ask your patient what's going on, right? We in our system have a dual response. So not every single patient that we go to is necessarily going to be an ALS patient. So we might start with a thorough OPQRST to get a history of present illness. Do we think this person is leaning towards ALS? And then with the blood glucose and all the vital signs and the temperature and the ECG and the story, we come to, yeah, I think this is going to be BLS versus ALS. But all of that has to happen in order to get a good sense of how we're going to work up this patient. Additional diagnostic tests should be done. Temperature should be a part of our vital sign armamentarium. Carbon monoxide when necessary, of course, stroke scale when necessary, glucose when necessary, so on and so forth. Okay, so we're going to kind of skip over assessment priorities because frankly, you all should know what those are. You're all working EMTs. You know what it is to get to a patient, establish level of consciousness, a primary survey, secondary survey, history of present illness, all of those questions that you ask. If you are not doing that a lot now, now's the time to get into that patient care role. Here, right here, this line, pediatric patients shall be defined as those patients who weigh up to 40 kilos or 14 years of age. So right there is the pediatric guideline. Okay. Now, I will say that sometimes it can be a little bit confusing because according to our needle cricothyrotomy program or our needle cricothyrotomy protocol, pediatric is 12 years and younger or 11 years and 364 days. So 12 and younger gets a needle crike, 13 and over gets a surgical airway. Well, that's different than this right here, which says the patient who's 14 or younger is PD. The important take-home point here is, for the sake of all of our protocols, when we're looking at adult versus PD, the magic number is 15. So a 15-year-old is treated under the adult protocol, and a pediatric is 14 and younger is a pediatric protocol, unless there is something specific in the protocol which says it should be different. So the needle crike says specifically in this protocol, it's 12 years and younger. Okay. For anaphylaxis, it says specifically it's greater than 6 months, or bronchospasm is greater than 6 months, or over 25 kilos, right? So you have to kind of pay attention to those guardrails. But in general, anybody who is 14 or younger is PD for the sake of our protocols. Okay, questions on that? That's kind of important. It makes the distinction between when you're treating PD and adult. If you don't know how old the patient is, go by secondary development. Do they have breast buds? Do they have hair under their arms? Are they growing hair on their face? That kind of thing. All right, ambulance stretcher operations. I hope you guys are skilled at data patient reports. Now, I will say, notice it says EMS system regulations require an accurate, concise, and properly documented PCR to be completed at the time of the care as soon as practicable. Yes, it is possible that you're on your late trip and it's an hour and a half past your time to go home, and you're exhausted and you've been out in the snow in 2 feet of snow, and the last thing you want to do is stay late and document a patient who, I don't know, has the flu, let's say. But the truth is, based on OEMS requirements, you are required to finish all of your trip sheets immediately following the drop off at the hospital. Now, that said, if you think that what you've done isn't going to functionally impact patient care, I've had paramedics call me and say, "Hey, Susan, I'm exhausted. Can I finish this trip sheet when I come in? I'm back in the morning. Can I finish this trip sheet in 8 hours?" Yes, that's fine. But you must have shift commander approval in order to do that. And I can tell you, if the patient, for whatever reason, may need more acute care, cardiograms, if they were hypothermic, if you did something in the field that may impact patient care downstream, then we're going to want you to finish that trip sheet. So it becomes more high stakes at the ALS level, and you don't have quite as much flexibility to say, it doesn't really matter if I write this tomorrow. You're going to have to finish it right away. So just be aware of that. People have been disciplined for not finishing documentation. And it's likely to get caught at the ALS level because I get called from the hospital, "Hey, I need this cardiogram. Where is it?" If you do a cardiogram, a 12-lead cardiogram, whether you transport or you refer to BLS, you are required to connect it, to attach it to your PCR. We have a whole protocol in place that says if you try and attach your digital 12-lead and you can't, you have to call the shift commander. The shift commander has to get involved. And if the shift commander can't resolve the issue right then and there, that monitor comes out of service and you get a new monitor. So it's not a small thing not to be able to do this. We have done our level best to try and work out the IT glitches that slow things down. But be aware, at the ALS level, documentation becomes even more important. Medications, be aware when we go through these protocols that you have two potential what's the term? Two potential bumper guards. One is the actual dose that you can give at one time, and then one is the overall dose. So, for example, ketamine is one of them. It says the dose for behavioral emergencies for ketamine is 4 milligrams per kilogram. So if your patient weighs 100 kilos, your maximum dose your dose would be 400 milligrams. If your patient weighs 200 kilos, your dose is 800 milligrams. However, your maximum single dose can only be 400 milligrams. So there are times when you might have to split up your dosing because the actual dose for your patient based on their weight is more than the single individual dose. So pay attention to those limits as well. Of course, you got to make sure now at the ALS level that all of your fluids and medications are temperature regulated. You guys carry epi and glucagon in your truck, so this shouldn't be new to you, but it becomes even more important when you have lots more fluids and drugs that you're carrying. Be aware that norepi and epri must be administered on a pump. That's why we still carry DOPA, because if you don't have a pump available, whether it's you physically can't find it or you go to use it and it's not working, we wanted you to have a backup. Exception principle. This is something that you should be aware that protocols represent the best efforts of EMS physicians to document and give you guidelines for evidence-based medicine throughout the Commonwealth. That said, there's no way that there's no way that physicians or any clinician for that matter can anticipate every single possible patient that you're going to run into. And if you run into a patient that for whatever reason requires a deviation from the protocol, it is understood that you may deviate and augment what you're doing with two critical caveats. Whatever you're going to do must be within your scope of practice, and you must have online medical control. So the line right here is deviating from the protocol should only take such actions as allowed by their training. That's scope of practice, and only in conjunction with online medical control, which means you can go outside protocol as long as you could do it if it were otherwise allowed. You can't do C-sections. You can't do needle thoracostomies because that is outside your protocol. All right. And of course, any such deviation needs to be thoroughly documented. This exception principle only applies to the protocols itself. It doesn't apply to regulations. So in other words, we can't change, Boston EMS can't decide of their own volition, we're going to change point of entry because that doesn't work for us and our system. That we can't do. But we can change an individual medical control option as long as we speak with our what's called affiliated hospital medical director. Okay, any questions on any of that? Okay, good. This advanced airway confirmation, again, because this is so important, it stipulates that if you put in advanced airway, you are confirming end tidal capnography and at least two of the following confirmation methods. So auscultating the lungs, visualization of the cords, presence of condensation in the tube. When I was first trained, those were the only three ways you could actually see. And then came the colorimetric end tidal CO2 change, which was great for when you first dropped a tube, but did nothing later on. And then we moved to waveform capnography, which is now the gold standard. So any patient with an advanced airway or who's assisted in BVM with or without an advanced airway must have recordable bag valve, recordable waveform capnography. Okay? Any questions on any of that? Okay, transport decisions, you guys know point of entry, so we're going to swoop by that. CQI, you don't have to know, that's continuous quality improvement. That speaks more, that's like for a systems overview and what the doctors need to know. So we're going to move right into high quality CPR. We just did it in cycle 1. Everybody should be experts. Everybody should be recertified. So I'm going to skip right past that. I know that there has been discussion about 8 minutes, putting the Lucas on, not putting Lucas on. Honestly, the goal of high quality CPR is to try and get uninterrupted, continuous cardiac compressions until you have a pulse back. And anything that you do that makes that happen, I'm happy with. So I'm not going to worry about, are you doing 30 and 2? Are you doing 34 and 2? Are you doing 18 and 1? because ultimately the goal is to get that Lucas on, to get continuous compressions, and then to intersperse ventilations with it. I will say that I did do a state exam recently where they went over AED, and apparently, according to American Heart, you're supposed to do 15 compressions and then shock the patient. But our AEDs charge up so fast that you might be at 3 or 4 or 5 compressions where it says shock the patient. Clinically, medically, as soon as you have the AED on and you're ready to shock, shock. Okay? Because the most important thing for VF is for somebody to convert that rhythm. That said, I know that when you're testing for AED, currently you're supposed to do up to 15 compressions and then defibrillate. I'm not going to get into that whole thing. I do want you to recognize that. And at the ALS level, the most important thing when you recognize VF or pulseless VT is that you do defibrillate. Questions on that? No. Okay. All right. Adrenal insufficiency, we don't see it that often. When we do see it, if we know about it, then the treatment of choice is a steroid. We carry solumedrol, also known as methylprednisolone. For adults, it is 125 mgs. Right there's the adult dose. And for peds, it is 2 mgs per kg to a max of what the adult dose would be. There is some guidelines here about, what is adrenal insufficiency and how might we be dialed into it if they don't tell us about it. I'll let you read that on your own. This is more about, what do we give when we think that it's there. I will say that one stress dose of solumedrol or hydrocortisone is unlikely to harm the patient in any way. So if you suspect they need it, go ahead and give it. Okay. And that's why it's under standing orders. There's actually, you can get medical control can give you additional doses of the same medications, but again, unless they tell you I have adrenal insufficiency, I wouldn't think that you would think to give a second dose. Okay, allergic reaction, we do a buttload of this, and I'm sorry, Benny's been through this already, but the important stuff that you all should know is at the ALS level, you can give upwards of 3 IM EPIs. I am not pushed, I am 0.3 for adults or 0.15 for kids. And then at the adult level, you can go right to epinephrine infusion. That's a standing order for allergic reaction. And that should kind of give you a sense of how deadly these can be. Of course, you also have standing orders for albuterol, if for patients that are bronchoconstricted, as well as Benadryl for patients that need the antihistamine. All of that is on standing orders. If you want to give norepi or dopa, you will need medical control for that. But all of that is under standing orders. It does depend on how acute your patient is. So obviously, if you try and give an epi infusion to a patient who's speaking in full sentence with a good blood pressure and heart rate, you're going to have to explain why you're giving a medication that should be used for the acute patient to one who's not. But if your patient has severe distress, remember, down here, severe distress is defined by stridor, bronchospasm, severe abdominal pain, respiratory distress, tachycardia, shock, edema. Basically, it is decompensating multiple organ involvement. That's how I look at it. Severe distress is decompensating multiple organ involvement. Then you should do that. Another thing to remember is because epinephrine in the adult patient is a standing order, both IM and in IV infusion. Epinephrine for anaphylaxis must be administered either through the auto injector or the check and inject, which we have. And every single patient who gets IV infusion should be on a monitor, especially patients that are over 40, because that's a very heavy catecholamine dose, and you want to make sure that you have appropriate cardiac monitoring. For the pediatric patient right here, you see 0.15 if they're under 25 keys and over 6 months old. So 6 months is the kind of the lower limit of what you can give. Can you give it if your patient is 2 months old? You can, but you need medical control. Medical control. Just get medical control if you think your kid is having an anaphylactic reaction. It is unlikely that a 2 month old will have a reaction, but you never know. Maybe they're getting a new formula and they're allergic to the formula they're getting. So just be aware that is absolutely medical control option. At the ALS level, you have albuterol is standing orders, Solumedrol standing orders, Benadryl standing orders. Don't confuse asthma with anaphylaxis. Magnesium is not part of this protocol. Anaphylaxis does not need a smooth muscle relaxant. That's part of your asthma protocol. So make sure you recognize that. And in the pediatric population, we talked about it this morning, epinephrine infusion is medical control only. Okay, so adults here, you can see paramedic standing orders, infusion of 10 to 50 mics per minute. For PD, your standing orders stop at Benadryl and you must go to medical control. Okay? So zero point 0.1 to 1 mic per kilo per minute. Again, on the pump. For patients under 12, they recommend that you best manage the airway with a BVM or a supraglottic airway. Again, this is about not taking the airway too soon, and because there are obviously dangers surrounding taking a pediatric airway. We at Boston do a lot of pediatric intubations. We're better at it. That's great, but there is risk. There is absolute risk to taking the airway of a pediatric patient. So you want to be certain that you need to before you do that. And hopefully, when you had all of your children's simulations, that was really driven home. Any questions on anaphylaxis? That's a really important protocol. We do a lot of it. Okay, good. Let's move on to altered mental status. Altered mental status, most important thing is a good assessment. And that's part of heart rate, blood pressure, respiratory rate, SpO2, end tidal, temperature, right? Patients that are very cold or very hot can and do become obtunded. So make sure your temperatures are in the normal range. Blood glucose, obviously, that's the other thing you want to make sure is in range. And if they are not in range, then we have standing orders for sugar. D10 is what we carry now. Everybody gets it. 25 grams and 250 cc's of D5W. The standing order at the paramedic level is 12.5. So you give half the bag and then you recheck. If they need more, you can go up to 25 grams, the whole bag. If it's a pediatric patient, then you are going to 0.5 grams per kilo. Okay, so that's 0.5 per grams per kilo. Be aware, you do have standing orders to treat hyperglycemic patients. And in the protocol, hyperglycemia is defined as anybody with a sugar of greater than 300. So your honks, although your honks aren't dehydrated, but certainly your DKAs, your sugars that are coming back 4, 5, 6, sugars that are coming back high, these patients should be plugged in and they should be getting fluid. Now, it does say that if they're in a hyperglycemic emergency and they're symptomatic, you give them fluid. But frankly, you don't have to wait for somebody to be altered to go ahead and give them fluid. If their sugars are very high, they are likely a little bit dry anyway, unless you think they are in honk and then they won't necessarily be dry. How would you know the difference, right? Well, what's their blood pressure? Is their blood pressure normal or is the blood pressure running low? Are they tachycardic? Are they normal cardiac? These are the kinds of things that you want to ask. Okay, any questions about diabetics or endocrine? All right. Always, as you know, pediatrics and adults, you give PO if you can. That's better. If for whatever reason they can't take anything by PO, then you go IV. If you can't get an IV, glucagon is the next best thing. Be aware that glucagon works with a healthy liver. So if there's any reason why their kidneys or their liver aren't functioning properly, you are less likely to get a robust response. If you are giving sugar, if you are giving fluids, it says hyperglycemia. It's a straight 500 ml bolus and then 250 mLs per hour. However, if you're giving fluid for a child, your standard dose is 10 mLs per kilo for the pediatric fluid resuscitation for the pediatric patient. In general, it's 20 mLs per kilo for anyone 30 days and older, and it's 10 cc's per kilo for neonates, which is birth to 30 days. But again, use your vital signs as a guide for how your therapy is doing. Always start lower. You can always add more fluid. You don't want to overload them and not be able to take it away. Okay, questions on endocrine and diabetes? No. Okay. There are tons of reasons why somebody could be altered mental status. That's why part of our H's and T's are hypo and hyperthermia, hydrogen ions, toxicities. This is just one of many. Keep that at the forefront of all of your differentials. Behavioral emergencies. This is a hotly contested protocol. This is what used to be excited delirium. We've gotten away from excited delirium. I sent out to everybody during the afternoon a couple of guide cards so that you would have some handy reference cards. I am going to send out one for toxidromes. I just put it together and I wanted the doctors to kind of put their eyes on it and vet it before I sent it to everyone. But when we think about patients that are having behavioral emergencies, there are lots of things that can cause it. Overdoses, toxicity, poisonings, all of those are part of it. So be aware when we go to treat these kinds of patients, we should do a thorough assessment or as thorough an assessment as we can until we can properly sedate them. Now, all of this whole first page is all about how to try de-escalation techniques because chemical restraint of a patient should be the last thing that we attempt in order to keep them safe. The first thing that we attempt is calming them down verbally, de-escalating them, having them connect with somebody on scene. But at some point, the rubber hits the road, and if you think they or any of the rescuers are becoming more and more in danger, then it's time to sedate them. And the drugs that we have on standing orders to sedate for adults is Haldol or haloperidol, midazolam, which is a benzo, and ketamine. Okay. So it's important to recognize per orders, you can use either or. All right. Now it does say if you want to use Haldol, you can use 5 mgs and midazolam, but just be aware, Haldol takes a really long time to work, well, a really long time. It takes 15 to 20 minutes to work, and most clinicians, myself included, have never used Haldol because it just takes way too long. By the time you're making the decision to chemically sedate, you need a much faster acting drug. So the two drugs that we look at are midazolam and ketamine. Now, if you say, my patient is, you get a call, the family says he's actively schizophrenic. He's a diagnosed schizophrenic who takes Haldol but hasn't taken it in a while, and this is really the best drug. Then I would say the best agents to use are a combination of midazolam and Haldol because the midazolam will work quickly and then the Haldol will act as the antipsychotic. But I will say that the majority of us, usually when we at the ALS level are chemically restraining somebody, we usually go right to the ketamine. We just snow them with the ketamine and then you can get medical control and say, hey, we've given him this. Do you want us to follow it up with Haldol? And sometimes if you have what's called an emergence reaction from ketamine, you will unlikely to have an emergence reaction because the ketamine dose is so high. But if you do, then you can include a little bit of Versed. Versed will reduce or counteract the emergence reaction, which is what an emergency reaction is it's a bad LSD trip, okay? Or it looks like a bad LSD. It's not an LSD trip. They're not on acid, but it looks like they're hallucinating, and it can be very, very scary and quite frankly very, very off-putting. So the fix for that is a benzo to sedate them and bring them down a little bit. The thing is, of course, when you give patients a lot of medications, then you have to worry about drops in blood pressure, a reduction in respiratory rate. Ketamine is supposed to have less cardiovascular impact than the other drugs that we carry, which is why a lot of people like it. But there does seem to be more and more evidence to support that as being less robust than initially thought. So, in other words, people do tend to have some drops in blood pressure, even though it was thought that ketamine didn't touch your pressures at all. So just be aware that any of these patients that you put these medications on board must be properly monitored. So, of course, you use these drugs to get them sedated, then you properly 4-point them or 2-point them. You get them on the monitor, the 12 lead, and you take them into the ED. Now, it's important to note, guys, very important, pediatric standing orders for chemical sedation is only midazolam. So if you want to use ketamine for peds, and I'm not saying you can't, I'm saying if you want to, you must have medical control. So just bear that in mind, okay? Questions on behavioral emergencies. Okay. All right. It's 6:51. Why don't we take 5 minutes? Everybody can stress. We're going into bronchospasm, which is really an important topic. We see a ton of it, and I want to make sure I give it due attention. So take a stretch, stand up, move around, and we'll come back at 6:56. All right? We will start recording and we will go back to screen. Okay. Bronchospasm, asthma. This is a biggie. The adult bronchospasm. Everybody can see the screen, right? You're all good? Okay, great. Excellent. Okay, BLS, you all know you can do albuterol, duonebs. You have been able to do that for a while. I think you can do a couple, right? At least two before you have to get somebody else involved. But certainly, CPAP is an option if they're not getting appreciably better. I've never been a huge fan of CPAP in the asthmatic because you can't control the expiratory pressures and they're already struggling to breathe against hyperinflated alveoli. I love BiPAP for it because then you can increase pressures on the inspiration and decrease pressures on the exhalation. So big fan of BiPAP when and if we get it through the ventilators. I think it'll be a game changer. But if you set your CPAP at a lower centimeters of water, such as 5, that's physiologic, then it actually can give your patient quite a bit of relief. So if they're getting some relief with a bronchodilator, but it seems like they're struggling to get a good breath or a deep breath, or they're getting a little fatigued, then sometimes CPAP can be enough to turn them around. That's standing orders. Be aware, standing orders for ALS now, we want to add on. You can do continuous inline nebs, duo nebs. I will say that it says here duo neb and then additional albuterol treatments with or without ipratropium bromide. Personally, I've never done more than 2 duo nebs, and then I go to straight albuterol because albuterol is a better beta agonist, and I don't want to shall I say, water down or dilute the amount of drug that I have with both the ipratropium bromide and the albuterol. So I would say if your patient starts off really sick, go with one Duoneb and then go straight albuterol. And as they get better, you can add in the Duoneb if you want. But albuterol is where you're going to get the best bang for your buck. So bear that in mind since you have two options there. Of course, steroids for the inflammatory process. So methylprednisolone or solumedrol we carry is good. And of course, for the asthma patient, you have a standing order of magnesium, 2 to 4 grams in the adult population. Be careful if you infuse it too quickly, they will get hot and flushed and hypotensive. So, if possible, you want to start it earlier, but give it a longer time to infuse. And MAG is part of the IV infusion library, so you can either hang it and just, kind of run it slowly, or it doesn't have to be on a pump, but if you choose to put it on a pump, it is there and you can do that. If your patient is acutely ill, of course, epinephrine IM is always an option. And that, if you'll notice, is even at the BLS level. So we are able to give it at the ALS level up to, I believe, how many doses? Benny, how many doses do we remember from the day session epi?
The 0.3, I believe we
It's
were,
one
we did
dose,
say two.
It looks like it's one dose. It actually does look like it's one dose.
one
Correct.
time dose.
Right. So if the first one doesn't do the trick and you want more, then just get orders from medical control for more. So again, it does matter what protocol you're working under. If you're working under the anaphylaxis protocol, you can give multiple doses of IM epi. If, however, you're working under the bronchospasm or asthma protocol, it's one IM epi and then more orders, more medical control orders. Okay. Now, here's the red flag, the caution flag, and we should absolutely be aware of it because many COPDs, because this isn't just asthma, this is bronchospasm slash respiratory distress. This is the bronchospasm criteria. You could be COPD, you could be asthma, you could be a mixed bag, it could be both. It is really important to know that the older you get, the more dangerous epinephrine becomes. Okay, so
Actually,
yes.
this morning it is two doses because if you look under the where where we're under the BLS where it says epinephrine and then it says the check and inject protocol
Yeah,
6.5, and when you go to protocol 6.5 it does say you're
two,
able
right?
to do two
Exactly.
dose. Yes, it's
Exactly.
two
Right,
doses
right.
from this morning, not
Thank you,
one.
thank you. Because I know we went back
It
and
was
forth. So
funny,
that's
except for this one little white dude came out.
okay. All right. So that's so for those of you that weren't here this morning, you'll notice check under protocol 6.5. If you click on 6.5, why is it not taking me to, huh? Okay. Sorry, guys. Let me let me reshare my Mass OEMS. Mass OEMS protocols. Sorry, hold on, give me 1 second. For some reason it froze up, so okay, here we go. I just want to make sure I'm on the right one. Here we are. Yes, share. Whoops. Share. Okay, we should be back. Okay, so check and inject. There is your 6.5 check and inject EMT basic. And remember, anything that a basic, advanced, a first responder basic or advanced can do, the medic can build on. So here's the medical director check and inject. You have adult dosing, 0.3 mgs. For pediatric, second dose may be administered in 5 minutes if necessary. So, Benny, thank you for remembering that, right? Same thing with pediatrics. A second dose may be administered. All right, so let's go back to our bronchospasm 2.6. Okay, so we have upwards of 2 doses that we give for epi, but if you're giving the epi IM, and it should be IM, not IV, always IM for live patients, IV only if your patients are dead or dying, and then you go to the IV area. The use of epinephrine in patients over the age of 40 or with known cardiac disease. So you might have a patient who's 25 who's got known cardiac disease, may result in cardiac complications. And even without epi, even just 3 or 4 doses of a beta agonist can really get their heart rate pumping. So always these patients should be monitored. They should get a 12 lead, even if they're turning around. Patients that you are concerned about cardiac complications should have a 12 lead. It should come further down the line. Obviously, you don't need it early. You want to get all the other drugs on board, open them up, get them breathing more comfortably. But then on the way to the hospital, put the 12 lead on, and then on a nice smooth patch, or maybe as you're backing in, snap that 12 lead and make sure you don't have to worry about anything else as you move forward. And of course, just be aware for pediatrics, mild distress, they're interacting with you, they're wheezing, they're moving good air. The more tired a kid gets, the more severe their distress. A quiet kid is a sick kid. And you can be much more aggressive with kids with epi than with adults. So if you think the child is tiring, be aggressive with that epi because that will really make a difference. Questions on any of that? Okay, good. Let's move on. And again, this is all just, serial nebs. Standing orders for peds is again Solumedrol and mag. 25 milligrams per kilogram for a pediatric dose of mag, up to a max of 2 grams. So adults are 2 to 4, but kids, the max dose is 2. And you should have 25 to mgs per kg. Okay,
Stephanie,
Solumedrol, yes,
just a quick question.
yes.
Um, on the mag, is there no age we can start at 6 months with the mag, or is it like with the
2 years. Says
steroids, 2 years in order?
it says right here, paramedic standing orders for a child age 2 or more who has known diagnosis of asthma. So it's known diagnosis of asthma. So you need a couple of things. Number one, they need to be acutely ill. You should not be giving magnesium to a kid who's having a mild asthma attack. So they need to be in severe distress. They need to have failed the epi. So you've given them albuterol, you've given them an IM epi inject. They're not getting better, or they're getting worse. Now you're reaching for the Solumedrol, 2 mgs per kg if they're over 2 years old, and then you're reaching for the magnesium. If they're under 2, it's medical control. Okay, and you see that right here through the standing orders. Okay? Good question. Any other questions? Okay, let's keep going. Hyperthermia. The single most important thing for a hyperthermic patient is what? Anybody who's worked a marathon or any sports event?
Cooling them down.
Cool them down. That's exactly right. Now, we don't have ice baths in the trucks, but you can jury rig an ice pack by cracking a couple of ice packs, wetting the patient completely with saline. Open up a bag, wet them down completely, take the ice packs, pack the groin, pack the armpits, pack their axilla. The goal here is to get the cool near their pulse points So that cooling air is bringing it back into the body. Try and get them down as quickly as possible. And you want to cool them to a temp of 102. As soon as they hit 102, you stop the cooling because you have that carryover effect. And with good air conditioning and a wet body, you're going to cool them pretty quickly. Of course, fluids are very important. The consideration should be 500 milligrams standard for an adult and 20 cc's per kilo for pediatrics. This is standing orders. If they seize, what do you do?
Midazolam?
Exactly. Give them a benzo. So if they seize benzo, keep cooling them, but also address the seizure. Hypothermia. All right. Now, hypothermia, we're talking about serious hypothermia in these conditions that we have outside. The important thing, of course, the therapy is warming them up, right? That is the therapy. But the important thing to
Deputy,
remember
you
is,
mute.
oh, I'm on mute. How about now? Can you hear me now? Okay, good.
Yes.
So it's weird with my computer. Sometimes I just all of a sudden you can't hear me. The fix for hypothermia is obviously warming up your patient. But in the meantime, what do you do? So the general recognized practice is if you cannot feel a pulse and you believe your patient to be in cardiac arrest, you begin resuscitation. However, you cannot expect medications to work at temperatures much below 88 degrees Fahrenheit, core temp. So if you're pulling out a patient from a snowbank who's 72 degrees and they're in cardiac arrest, usually they will be in either asystole or bradycardia. It is reasonable to give them one dose of epinephrine, to start. But if that doesn't work, it is also reasonable to do high quality CPR and ventilations until you get to the hospital because nothing will work until you warm them up. And giving them 10 doses of epi only to have that get dumped into their system all at once they warm up enough isn't really the best thing to do. If you're not certain, reach out to medical control, tell them this is my patient, this is their core temp, this is where we're at, we're working in arrest. Do you want me to continue giving
We lost
medications
your
or
voice again, Deputy.
oh God. I'm sorry about this, guys, but this is just all right. How about now? Is that better? Okay. All right. Be aware, again, patient is in, it says here, if patient is in cardiopulmonary arrest, manage as PEA and asystole, which is epinephrine, and treat causes. So the whole point is if you suspect that the cause is that they are hypothermic, then you have to warm them before you do anything else. Let me go back to the hypothermia. Where are we? Here we go. This is hypo. Ventricular fibrillation. If your patient is in VF, one shock, and good high quality CPR, and haul ass to the hospital because these are patients that are ECMO patients. And you don't want to spend 25 minutes on scene trying to break refractory VF for a patient who's got a temperature of 70. These patients are going to be in VF. In fact, if you have a patient who is obtunded and you suspect is hypotensive and you suspect needs an airway, BVM these guys. Because if you try and take their airway, you are likely to precipitate VF and then you can't get them out of it. So the name of the game with acutely hypothermic patients is gentle management and rapid transport. If they arrest, treat them per the arrest protocols, but be aware they probably won't be successful until you get them in and you warm them up. Hypoglycemia, same thing. It is rare for
Deputy,
somebody to, yes,
sorry
you
to
can't
bother
hear me?
you. Just
Yeah.
on that note, on the airway status, I know you said
hmm
no advanced airway. Would you consider a supraglottic?
Well, the reality is that a supraglottic airway can trigger the laryngeal spasm in the same way that tubing them can. I'm not saying don't put an airway in, don't misunderstand me. If you don't have a good airway with a BVM, then absolutely put in an advanced airway. You have to. But here's the thing, and this is I will echo the lecture I gave during cycle one. Just because it's simple doesn't mean it's easy. If you can learn how to get a good bag valve mask seal and you can effectively ventilate your patient with a BVM, that is a safer way to manage their airway than to put down a tube or supraglottic airway. Is it easier? No, it's not. It's harder to BVM somebody than to put in an advanced airway, but it's safer. I want you to understand the difference because patients that are hypothermic can VF. Now, that being said, not every patient does, right? There are lots of patients that are cold that do just fine. I'm not telling you what to do. I can't tell you what to do. Everything is different. If you're driving in from, let's say you're coming in from Deering Road, right? Deering Road to BMC in 2 feet of snow is a 20-minute drive. It might be really, really hard to BVM a patient effectively for that long. And you might say, you know what, it's worth the risk to try and tube this person because I can't effectively ventilate them, bumping down the road. And the only way you're going to know that is you watch the monitor, you watch your patient's end titles, and see how it goes. If you ventilate them and it's easy and you can do it, then fine. If you're trying to ventilate them and you can't, then you tube them. But if you are at 790 Albany Street with a patient who's in a snowbank, it's really not the best idea to put a tube down their throat because you're only going to have to bag them for 2.5 minutes. So that's why I say you really have to, it's all about what the cost benefit is for what you're doing versus what can be gained. You're looking confused, Michelle. Oh no, okay. It's just, you're deep in thought.
I understand.
Okay.
Yeah,
Okay.
I was thinking, but I'm listening to you.
Okay, no, that's fine. And I want you to understand, since this is a protocol discussion, 2.8, if patient is in cardiopulmonary arrest, manage as you would a cardiac arrest, understanding that your H's and T's are going to play into your management. Okay, let's keep going. Of course, do not administer anything orally. If they're obtunded, no kidding, they don't have a gag. Nerve agents. We had a long discussion about this on the day session. I sent out a couple of guides and one that will be coming on toxidromes because I know a lot of you guys asked, can I have a refresher on the toxidrome constellation? So that will be coming out shortly. The thing to remember is we have removed diazepam from the gray boxes. So in your trucks, you all have black boxes, and you should be carrying atropine and tupam. Have you looked at those black boxes? Have you been in them? Do you know what's in them?
They're
No.
typically
Okay.
sealed.
Okay, they're typically sealed. That's what I thought. Well, here's your. I would say the next time you're in the truck, crack it open and look because now what you have is probably almost identical to what the ALS has because the only difference that the ALS had was we had auto inject benzo. That's come off the truck. So now you have atropine and tupam, which are both anticholinergic drugs to use as counteragents for cholinergic nerve attacks, right? So that's your organophosphate poisonings, your Benadryl overdoses, your TCAs. If your patient starts to seize, if they are a serious overdose, I think of the patient that we had recently. I'm not sure if it was BLS or ALS rounds, but the patient took an overdose. I think it was BLS rounds. The patient took an overdose of Benadryl. And they were presented classically as a cholinergic poisoning. They did not seize, so they did not need Versed. But if they do seize, we carry midazolam. We just simply don't have enough for 50, 60, 80 people for a WMD attack. So if it's 1 or 2 people that do it, then we just treat them with Versed as we normally would any other patient that was seizing. Okay, I will say that this nerve agent card it's obviously part of the state treatment protocols. I found it very complex and difficult to visualize if we were going to have an MCI. So what I did was, and I'll show you for those that didn't see it, this is the card that I came up with. You all have it in your email. Here is the card, nerve agent dosing. Let me share the right one. Now, this is what it looks like. So this is the card that is in the ALS drug box. I didn't put it in the BLS, but certainly, I mean, now that we're talking about it, I can. So this is the front of the card. And if you'll notice, let me make this a little bit smaller. Okay, so everybody can see this, okay? So it's 2-PAM, right? This is the pediatric dosing. So the atropine comes in little 1 milligram vials, so that's easy enough to do. But we break it down into 3 different weight dosings. If the child is less than 20 kilograms, you take 3 mLs of the saline, you mix it with 1 gram of the drug, you make 300 mg per ml, and you give the child 1 ml. So it's very basic and straightforward. If the child is 20 to 30 keys, and again, you use the Broslow tape to determine how big they are, then they get 1.5 mLs. Again, mixing it this way. And if they're over 40 keys, it's a 600 milligram dose, which is a standard adult dose, and they get 2 mLs. Okay. And then on the opposite side, that's pediatric, but all adults get 600 milligrams, which is 2 mLs when you mix this up. On the opposite side of the page is the mild, moderate. There's the opposite side. Mild, moderate, and severe exposure. And it tells you if you have mild, you get 1 to 2 milligrams of atropine and no 2-PAM. Again, you're giving atropine as an anticholinergic drug for a cholinergic poisoning. If you have moderate symptoms, they get 2 milligrams of atropine and a 600 milligram dose of 2-PAM. That's the duodote. That's what you guys have in your black box. So you just take that auto injector, you hit them with 1, and that's for the moderate. And if you have 10 or 15 or 20 people, everybody gets 1 injector. If, on the other hand, they have severe symptoms, and how do we know they're severe symptoms? You have the sludge or the dumbbell, lacrimation, salivation, defecation, they're leaking from everything, acute respiratory distress. They get 3 duodote injectors. So mild is 1, moderate is 2, severe is 3, and then if they're seizing, they get Versed. So that was kind of the easy way that I kind of conceptualized it, and was hoping this way people would know how to determine how many of these duodotes they get. Okay, now that's for BLS. In the ALS box, you actually have the drug in powder form, and you can mix it, reconstitute, and make it for 30, 40, 50 patients. But since we have the protocol right here, let me share it again with you. I figured I'd kind of go over that with you. All right, questions on that? Okay, good. Let's move on to obstetrical emergencies. I will say this is one of the few protocols that are changing significantly come June. June of 2026, we are introducing oxytocin as a new drug for postpartum care. You do not have to know that for the exam. I won't ask you about it, but since we're talking about it, I will let you know. The important thing for you to know here is the difference between eclampsia and preeclampsia is what?
Seizure.
Seizure, exactly. So before they seize, it's pre. After they seize and they need drug, it's post. The drug that will help them is MAG, but we also give Versed to stop the seizure. All right. So we start with 2 to 5. it's 2 to 6 milligrams. I believe it's 5 mgs per dose. So most people will do 2.5, 2.5, 2.5. So we'll start with the standing order. We'll start with 2.5 and then follow it up with 2.5, and then they'll get the mag. If they're still seizing, then you get medical control for more drug. Of course, if you need calcium chloride, I can't think why you would, unless they are, there you go, antidote for magnesium. So if you give mom too much mag too fast, they become hot and flushed, and most importantly, drop or tank their blood pressure. What don't we want to do for the baby? Right? I mean, if we make her blood pressure too low, she can't perfuse the placenta. So you will give calcium chloride for an antidote for too much mag, but that is medical control. Okay? Questions on that? All right, good. Let's move on to PALS, or neonate care. The most important thing to remember with pediatric resuscitation is stimulate, dry, and ventilate. Stimulate, dry, and ventilate. This is hopefully something that you took away from cycle 1. If if they come out, that the baby comes out depressed and they do not have a heart rate greater than 60, resuscitation of the newborn, here we are. 60 to 80 is dry and continue to ventilate. Less than 60 is CPR. But we aggressively want to ventilate them in the first 30 to 60 seconds before we start CPR, because oftentimes all they need is to stimulate that respiratory drive. And once they stimulate that respiratory drive, their heart rates will shoot up. So just monitor really closely, watch them. And again, positive pressure ventilation right here. This is the sweet spot. Positive pressure ventilation for 1 minute. If the heart rate remains less than 60, then you start chest compressions. Okay? If they don't come back with chest compressions after a minute, you then go ahead with epi. But for neonatal resuscitation, very much like bradycardia and PEA for adults, it's really epi driven. You should be aware, if they have VT or VF, then the energy setting for defibrillation starts at 2 joules per kilo and moves up to 4 joules per kilo. If you need to cardiovert them, I had a 7-day-old neonate who had been diagnosed in vitro with WPW, who I found depressed with a heart rate of 240. So it's not unheard of that you'll have a congenital abnormality that you'll need to address. But honestly, I would first try the dive reflex and vagal them before I would go to cardiovert them. If they have a pulse and they're newborn, just sit on it for a little bit. Neonates are Benny, hold on 1 second. Resuscitation, again, in the newborn is technically the neonate. Remember, they're 10 cc's per kilo over 5 to 10 minutes, and then reassess. Benny, you had a question?
Yes, going back to where it says for the heart rate less than 60 beats per minute, initiate CPR as indicated. But then
Yes.
it says initiate positive pressure ventilation for 1 minute. So is that before chest compressions, or are we doing
Right.
chest
So,
compressions and
that's a,
then
so that's a good question. I can tell you that it depends on whether you're following neonatal resuscitation or newborn resuscitation or PALS. So with newborn resuscitation, the recommendation is that you do positive pressure ventilation for 30 to 60 seconds before you start compressions. With PALS, if you can't feel a pulse and their heart rate is less than 60, you start compressions immediately concurrently with ventilations. And I think that's because the sense is a newborn is likely to be depressed, and you need to stimulate their respiratory drive. And once you stimulate that, their heart rate will take off. That said, let's go to the document itself. Resuscitation of the newborn. Dry, okay, so let's read it out. Dry the infant, place them on a blanket, ventilate if ventilations are inadequate or chest rise, which one would expect, right? Because they need to be resuscitated. Suction and initiate positive ventilation at room air. So no oxygen, just the BVM, and ventilate them at 40 to 60 breaths a minute. So that's like so a breath every 1 to 2 seconds. Okay. For heart rates less than 60 beats per minute, institute positive pressure ventilation, oxygen for 1 minute. So it says it right here. If your heart rate is less than 60, first you institute positive pressure ventilation for 1 minute. And if the heart rate remains at 60, then you start compressions. So there's your answer right there. Okay. For the newborn, you give it 60 seconds of aggressive drying, stimulating, and ventilating, and recheck. A minute later, you recheck. If the heart rate remains 60 to 80, but is rising, then it's just ventilations. If it's 60 or falling, it's CPR. Okay? That's a good question. It's important. Of course, once you do that, now you put the child on cardiac monitoring. And this is kind of a heavy cognitive load because not only do you have a tiny infant who's critically ill, but you have to pull out your pediatric dots. I mean, you could use adult dots, but imagine that the child is so tiny, it's going to take up everything, right? So you're going to get them on the monitor. You're going to see, you hope that you see a tachyrhythm. Hopefully it's nice and tight and narrow. Anything less than 200, leave alone because you expect a newborn to have rates of 160 to 180. That's what you expect, right? So we're not worried about that. The only time we get worried is if it's wide. And then if it's wide, we have to say, okay, are they hypotensive? Because I'm so nervous. I'm literally in P95. I'm scared out of my wits and I can't appreciate a pulse or a blood pressure. Or is it that they're really not perfusing and I need to convert this neonate VTAC? So it's something you have to ask yourself. If they are wide, and you all know how to identify VTAC, if they're wide and you cannot appreciate a blood pressure, then you cardiovert at 0.5 to 1 joule. I can tell you that in this patient population, it's actually very useful to use other cues. If they're limp and they're blue, you light them up. If they're moving around, right? So if they look like they should have a blood pressure, give it a few minutes. Try and see if they stabilize. Okay, I kind of wish Dr. Weber was here because she does rotations in the peds, and I think she would have even more useful advice, I shall say. I can only speak from my own personal experience with newborns, and acutely ill neonates. And sometimes you just have to kind of bite your tongue and just watch them closely, and they will regulate. These are tough lines to get, but again, it doesn't mean you don't try. So you use a 24, you can go for a saphenous vein. The nice thing is that their skin is practically translucent. So you have to have extremely good technique, and that's something you'll work on, but you absolutely can get IV access in these little babies, okay? If you can't get IV access, you do what? Yes, exactly. Stan is like, you drill them. That's right. You get an IO, which is also hard because they've got tiny little bones, but that's okay, right? We do what we can. All right. And then, of course, if you'll notice, interestingly, I want you to really take note, Epinephrine is not a standing order in this patient population. This is newborn resuscitation. You want to give epi to these kids, you got to talk to a doctor. Because most doctors are going to say, well, what do they look like? Are they moving? And they might tell you, hold off, right? Give these kids a chance. Just vigorously stimulate them, bag them up, give them a chance to adjust. They just came into this incredibly new environment. Okay. Any questions on newborn resuscitation, when and how to start ventilations and okay, good. Let's go to pain and nausea management. This is an oldie but a goodie. I love it. The important thing to recognize is we have a lot of different agents at our disposal. At the ALS level, we really don't reach for the ibuprofen or the acetaminophen. We go right to the fentanyl and or the ketamine. Most of our pain that we treat is going to be more substantive. And important thing to recognize is standing orders. So Zofran, standing orders. 4 mgs for adults and 2 mgs for kids. And what constitutes, a child, a pediatric that we can give Zofran to is any child over 25 kilograms, okay? For a child under or up to 25 keys, oh, I'm sorry, I take that back. For a child up to or under 25 keys, you can give 2 milligrams, PO or IV or IM, either one. But if they're over 25, then they constitute like an adult dose and they get 4 milligrams. Personally, I don't like giving PO Zofran to somebody who's nauseous. For one thing, we don't have any water in the truck, so there's no way for them to swallow it. So really, we don't do PO meds in our system. We do liquid, that's why we have liquid ibuprofen, liquid acetaminophen. But if the child is vomiting uncontrollably, they've been ill for the past 3 days, and you want to give them something to stop that, then the right way to do is to start an IV and give them some IV Zofran. Fentanyl, 1 milligram per kilogram, and that dose is pretty much the same regardless of age, because it's weight-based. So you can see if the kids, whatever their kilogram is, it's going to be 1 milligram, microgram, sorry, thank you, 1 microgram per kilogram, up to a max of 150. If you're going to give more, I can think, there are plenty of conditions, bad broken bone, burns. You might want to give more, especially if it's a long ride. Just get medical control and you can give more. I'm sorry, guys. And of course, last but not least is ketamine. Ketamine has 4 different dosing depending on what you want to do. I sent out that card to everyone. You should have it. Pay attention to the protocol under which you're operating because it does matter. For anesthetic dosing, in our system, it's 0.1 to 0.3 milligrams per kilogram. So you can see here, standing order for adults is 0.15 milligram per kilogram, unless you're going up the nose. And then typically anything we give up the nose, we double the dose. So it's 0.3 milligrams per kilogram up the nose, okay? Now, if you're going to, and this is new for Benny, who was here this morning, if you're going to do sedation, so this is procedural sedation dosing, you'll notice that the dosing is 1 microgram per kilo for adults, but you can only give midazolam to kids. Okay, no fentanyl or ketamine for therapy for kids. You want to give midaz for children. If you want to give ketamine to kids for procedural sedation, you can do it, but you need, especially for children, medical control orders. Okay, so just bear that in mind. Okay. Again, anesthetic dose, 0.1 to 0.5 ketamine. It's 1 milligram per kilogram for intubation or post-sedation use. So let's go back to questions on...
But we won't have to worry about that, right? For the exam, the sedation and Because we'll
You
do that
might,
with.
you might,
Okay.
you know that you definitely might. The electrical cardioversion and pacing is absolutely on the table.
Oh, that's
So,
right. Okay. All right.
right, so right, so
Electrical therapy. Okay. Yep.
right, it's electrical therapy. That is for electrical therapy. Sorry, I kind of lost my place here. Let me make sure. Here we go. Uh, oh, sepsis. We don't want sepsis. Here we go. Here we go. Pain, nausea. Okay. So the reason that this comes in, this protocol cross references, is because technically you're using this for pain management, right? So you're sedating for electrical therapy, sedation analgesia for electrical therapy. Now, I personally like Versed the best because there is an amnestic property, a retrograde amnestic property that the other drugs don't necessarily carry. But that being said, Versed can drop your blood pressure. So if your patient has really, really low pressure, Versed's not the best drug to use. Ketamine is a better drug to use if your patient's pressure is low and you need to pace them. Okay? And again, paramedic standing orders for pediatric pain management. You've got Motrin, ibuprofen, Toradol, or ketorolac, or fentanyl. But if you want ketamine for pain management, go to medical control. I know it's a little confusing. It's like, well, why can't I just if you're not sure, just go to medical control. Okay? All right. Next, we are going to go to poisoning. All right. Poisoning, substance overdose, toxicology. This is for both adult and PD, so let's pay attention to where the little pediatric signs are. Of course, Narcan for opioid overdose is standing orders. You can give up to 8 milligrams. We don't give that much, but you can. I will say if you've given 2 doses of Narcan, sorry, up the nose and it's not working, then you should be starting in line and giving it IV because it'll work faster and more quickly IV. And there's no reason why you can't give zero point 0.5 milligrams IV and just wake them up if you think that's the problem. Again, pediatric is zero point 0.1 milligram per kilogram. Double that dose if you're going intranasal, but this be very, very careful because kids that you're giving Narcan to, and very well you might be, this is resuscitative status post birth for kids that are born dependent. And if you give them Narcan and you pull them off, they can seize. So just be mindful of that. And you really only want to give enough to get their respiratory rate up. In fact, I've recalled 2 separate instances where I had a newborn with respiratory depression whose mom self-disclosed narcotics use. And we elected not to give Narcan and just bag the child because we didn't want to aggressively detox them or aggressively withdraw them because that's really painful and uncomfortable. So we elected just to bag them up and get them into the hospital where, again, this is a neonate where they could be better monitored by the experts. Okay, calcium chloride, the overdose of choice for calcium channel blocker. And I want you to be aware this is medical control. So all of these things here are if you think you have it. It says cyanide antidote kit. I was under the impression we're going to have to look as we get closer. We're going to have to see the burns because I was pretty much under the impression the cyano kit was standing order. We'll double check. It might be just if you're using, yeah. You know what this is? So there's 2 types of cyanide antidote kits. One is with sodium thiosulfate and sodium nitrate and amyl nitrate. We don't use that. What we use is hydroxycobalamin. I'm pretty sure that's standing order. We'll double check when we get to the burns, but it's 5 grams for adults, and for PDs, it's 7 milligram per kilogram. So if you suspect cyanide poisoning, that is a medical control option for adults and peds. Glucagon for beta blocker overdose, obviously anywhere from 1 to 5 milligrams, and peds is 0.5 to 1 milligram per medical control. If you think somebody has cocaine toxicity, then sodium bicarbonate would be the right drug of choice. Atropine for organophosphate poisoning. Um, Pulmonary edema management would be Lasix. That's pretty much your toxicology. Any questions on that? Now, notice hyperkalemia isn't in this constellation of protocol because hyper K allows you to give calcium on standing order. So, calcium chloride as an antidote for calcium channel blocker toxicity is medical control, but calcium chloride for a suspected hyper K is standing orders. There's the distinction. Seizures, you have standing orders for midazolam. You can go up to 5 milligrams IVIO or 10 milligrams intranasal, but you can't do both. All right. If you want more than 5 milligrams IV, or if you elect to do, you try to get an IV, you can't, you end up giving 10 up the nose. Now you want to give more once you get the IV, just get medical control for it. And of course, mag sulfate, if you suspect preeclampsia or they are eclamptic, if you suspect hypomagnesemia, or if they're in torsades, that is a standing order, okay? But they need to be seizing, of course. All right. If they're not seizing, then you should be getting medical control. Benzos may be contraindicated in head injury or hypotension. So I think this benzos being contraindicated in head injury has pretty much, I don't want to say been debunked, but it's the reason that it is contraindicated in head injury is there is genuine risk for hypotension. That is true. And what is one of the three cardinal no's for head injury or traumatic brain injury? We want to aggressively avoid hypoxia. We want to aggressively avoid hypotension, and we want to aggressively avoid hyperventilation. So because we want to aggressively avoid hypotension and a benzo can cause that, that's why it's relatively contraindicated in patients with a head injury. Any other questions about that? Okay, peds, we continue. Always, always double and triple check that a seizing patient is not hypoglycemic, is not hypo, or more importantly, hyperthermic. Check these because this can be the reason for them seizing, and no amount of benzo will necessarily break that until you fix the root cause. It might stop it transiently, but then they're going to seize again. So once you establish that those things are probably not the issue, then you move on to benzos. And for peds, it's 0.1 mg per kg to a maximum single dose of 8 milligrams. That's a pretty hefty dose. Or midazolam 0.2 mg per kg to a max of 10 milligrams. Again, that's doubling the dose intranasally. Okay.
Deputy,
Yes.
question. How
Yes.
come on midazolam, the doses for PD are higher than the
Is
adults?
higher. You know what? I'd ask that too. I'm not sure.
Okay.
I've not gotten a good answer. I think it's probably because kids can chew through it more quickly. But honestly, I'm not sure. I've often wondered that myself. It's a good observation, but I can't give you the answer. I'm sorry. I'll look it up for you though. Okay. I'll check with our people. Of course, be really careful giving anything orally for patients that are obtunded or don't have a normal gag reflex. I don't think I have to tell you that. You guys know that. Okay, shock. Let's go to shock. Very important. I'm glad to say you all did really well on the shock section. So I don't know that we have to spend too much time on this. The important point here is, if you'll notice, there is nothing understanding order beyond fluid administration for general shock. So cardiogenic, distributive, hypovolemic, obstructive. There's nothing under standing orders for shock. You have to go to medical control, right? It says consider one of these three things, norepi, epi, and dopa. But in order to get it, you got to go to medical control. The exception to that rule is, Benny, what's the exception to that rule? You're the expert.
I'm sorry.
The-
It was I think it was septic. Septic
no,
shock
not
is
septic.
not
What
septic.
we've talked about it.
Anaphylaxis. Anaphylaxis.
Anaphylactic, that is exactly right.
Anaphylaxis. I
So
apologize.
anaphylactic shock, we can go after 3 IM epis, we can start on standing orders. We can start epinephrine drips, 10 to 50 mics per minute. I refer you to right here. It says, you see, distributive shock. So cardiogenic, hypovolemic, obstructive, neurogenic, those you have to get orders. But for distributive shock, we cross back to epi. And here's paramedic. If 3 doses of IM epi are not effective, administer epi infusion at a rate of 10 to 50 mics per minute by infusion pump. Okay. So be aware that is standing order, but that's the only one that's standing order. All right, let's continue. Shock. Now, let's go to sepsis. So we talked about anaphylactic. So now we're talking about septic shock. For patients with controlled hemorrhage, it's, of course, TXA and IV fluids. We'll get to that in a moment. Hold on just 1 second, guys. Hey, can I call you back in about 40 minutes? All right, I'll talk to you soon. I'm teaching. I'm teaching. I'm teaching. All right, I'll talk to you later. Bye. Okay. Sorry, that's my brother, and I have to take his call because he never calls me. All right. Okay, so distributive shock. Again, anaphylaxis is we've spoken about spinal cord shock. We're going to get to that in a second. There's no standing order here except for 20 mLs per kilo. That is standing orders. Again, they're telling you be thinking about norepi or dopa, medical control option for all of these other shocks is norepi to start. And you'll see it over here under shock. Where's my shock? I just had it. Shock adult. Okay, so if you'll notice, the first drug of choice under these shocks is norepi. We spoke about it a little bit this morning because norepinephrine has more alpha, pure alpha, than epi, which has beta properties. And for the shock states that we want to just squeeze and not make the heart work harder, we want to avoid the beta agent that is epi and just try and give as much alpha as possible. However, for anaphylaxis, where we really do want to see a little bit of bronchodilation, we want that as part of the treatment. We look to epi. So just be aware, norepi and epi are both good pressors, but norepi is first line agent for cardiogenic, distributive, hypovolemic, and obstructive shock, whereas epi is frontline for distributive, which is anaphylaxis, and that shock is standing order. Okay, questions on that? Again, shock pediatric medical control may order norepi or dopa. It says think about the etiology. If you think it's anaphylactic, then you can go with epi. Otherwise, you should be thinking norepi. All right. Patients with hypotension or hypovolemic shock, you should really restrict IV fluids, only maintain mental status, right? We want to talk about permissive hypotension because we don't want to increase their pressures, blow the clots, and then cause them to bleed further. Any question on that? Okay, I'm gonna keep plowing through because we still have quite a bit, and I told the day guys, you can't get this all done in 2 hours. I respect if anybody has to leave at 8, you can, but I'm just going to keep going until we get through it all. So, pediatric sepsis, adult sepsis, right? So, of course, you want to manage the fluids, aggressively give fluid. There is no standing order for sepsis. Again, you want to get medical control if you think these people need pressure support, nor Epi 1, Epi 2, Dopa 3. But all of these are medical control options. It's supportive care, aggressive fluid therapy, especially for septic shock. They're very, very low. They're very, very dry, and then pressure support. And how much fluid do we give for septic patients? What's the dosing?
500 milliliters.
500 mLs or 20 mLs per kilo. Okay, so you have 500 mLs as a standard bolus, but 20 mLs per kilo is also appropriate. Okay, why does it keep doing that? It keeps sliding back. Hold on, where are we? Pediatric. You want to manage fluid. You want to manage glucose. Check these folks' glucose. Again, it says fluid bolus is 20 cc's per kilo. Reassess patient and give a second bolus. You can do that up to 2 more times. So you should be giving up to 60 mLs per kilo before you're considering requesting medical control to press them. All right. So these folks take a lot of fluid. Blood pressure for pediatrics. Bear in mind, if their blood pressures are low, we're way behind the 8 ball. Don't be waiting for kids to get hypotensive before you're aggressively managing them. And of course, it's age times the age. It's years times 2 plus 70. Okay, so however old they are, if they're 2-year-olds, it's 2 times 2 plus 70. The 74 is the baseline pressure. If they're 10 years old, it's 70 plus 20 is 90. That's kind of how you guesstimate what their blood pressure should be. You guys are excellent managers of stroke. I do not need to tell you that's a BLS skill here at Boston EMS. The only difference is at the ALS level now, if they're very obtunded, you have to worry about seizure potential and airway management. So just bear that in mind. Hyperkalemia. If you think your patient is hyperkalemic, and I know that you guys have been doing a lot of work on what is a hyperkalemic patient, you see the pointed, painful T waves. You see the elongation of the QRS. You see the dropping of the PR or the elongating of the PR interval. And you suspect hyperkalemia based on history and cardiographic findings. You should have both. Again, if patient presents with clinical factors predisposing them, so they need to have a history, and the 12 lead is consistent with moderate to severe hyper-K, then you can go ahead and treat on standing orders, calcium and albuterol. You shouldn't just do it because you've got a wide complex and I don't know what the hell is going on. There should be some reason that you suspect hyper-K. Hyperkalemia can lead to sudden cardiac arrest, so they do say anybody who has renal or who has a wide QRS of unknown etiology or peak T waves or VF that is refractory, you can consider calcium as a therapy. Questions on management of hyper-K and why we do what we do. We do it a lot, so you should know it. Okay, we're going to skip over home dialysis because I'm not going to test you on that. I don't think we need to know. And frankly, I think the cardiac section is far more important. You guys did pretty well on the cardiac session, so we're going to kind of fly through this. If you have any questions, stop me. Otherwise, I'm just going to keep going. Just bear in mind that you need a blood pressure of 120 or more to on standing orders. Give your nitro in the setting of ischemic chest pain. If you think that the patient has ACS, even if they don't, so if they have a cardiogram suggestive of ACS and they have a mimic like shortness of breath, you can consider giving nitro. But again, nitro is really for chest pain. So if they have a mimic, it's probably not going to help them as much. unless they have pain or discomfort. Fentanyl is the cardinal backup if you don't want to give nitroglycerin 1 microgram per kilo. And of course, if you see ST elevation, then definitely aggressively manage pain with fentanyl. It won't drop their blood pressure, and it'll be safer than nitro. What will really save them, what will really move the needle in outcomes is, of course, aspirin. So that goes on first and foremost. You guys all know about how to identify STs. That's, you just have to do that. And if you struggle with ST elevation, we can, kind of study it a little bit more. You can do some extra sessions, but let's just keep going with protocol for now. Just be aware if you think there's ST elevation, point of entry is a cath lab. And we're lucky here in Boston, we have plenty to choose from. Okay, fib and flutter. What really trips people up on is what is the cardioversion energy setting. So difference always, what you should always ask yourself in any exam, stable, especially in the practical exam, guys, hopefully you're going to get to it. Is the patient stable or unstable? And in a practical exam situation, if you're not told, offer both options. If my patient is stable, I'm going to go with either diltiazem or metoprolol. Dilt if they're on a calcium channel blocker, metoprolol if they're on a beta blocker. Diltiazem is better in general. It's less cardioreactive. Dosing is 0.25 to 0.35 for adults. And then if that doesn't work, 15 minutes later, you can follow it up with 0.35 milligrams per kilo. If, on the other hand, they're unstable, then it's energy. So be comfortable saying these are my two treatment options depending on what I'm giving. If they tell you your patient has a pressure of 60, is cool, pale, diaphoretic, and complaining of chest pain, then you sedate and cardiovert. 200 joules for atrial fib. Okay, so it's unstable is 200 joules for AF. And it says a flutter at 50 joules. Spoiler alert, I think they're going to switch it to 100 for everything in July. But for now, because I'm not entirely certain, atrial fib is harder to cardiovert. So irregular is harder. It's 200 joules. A flutter is easier. It's 50 joules. And just remember, cross-reference sedation, your protocol. You can use either Versed or ketamine, or a combination, although I wouldn't do both, but one or the other for sedation or sedation before cardioversion. If the patient's on a beta blocker and you want to keep them on the beta blocker, then your dose is standing order is 2.5 to 5 milligrams. It's always better to start low and then give them a second dose because you can always give more, but you can't pull away. And again, in order to treat on standing orders, your patient needs to have two things. Remember, they have to be symptomatic and they have to have a heart rate of greater than 150. Now, symptomatic can be a lot of things. Symptomatic can be, I feel funny, I have palpitations, I'm short of breath. It doesn't have to be crushing chest pain, diaphoresis, nausea, vomiting, and ST elevation, right? The important thing is it has to be above 150 and it has to be symptomatic. If you don't have those two triggers, then you have to get medical control. You can still treat, but you need medical control for it. Okay? Finally, if DILT or metoprolol isn't the drug of choice, you can always ask for amiodarone medical control. And of course, if you're not sure if it's if you're not sure if it's AF or an SVT, you can always request medical control for adenosine. But honestly, then if you think it needs adenosine, you're not under AFib protocol. You're under SVT protocol. Questions on fib or flutter? Okay, so I will say that if the patient has a history of Wolff-Parkinson-White, or second or third degree heart block or sick sinus syndrome, DILT is contraindicated. Okay, so be very, very cautious in patients with these black box warnings, if you will. If they have a history of such, get medical control and go with amio. It's a safer drug. Okay. Of course, it says do not use IV metoprolol with IV calcium channel blockers. That is, don't mix the two together. If the patient takes metoprolol but hasn't taken their medication in a week, it is completely appropriate to give them calcium channel blockers. They just don't want you to mix them concurrently because they have a synergistic effect. Okay, bradycardia, we always talk about high grade blocks should get immediate transcutaneous pacing. A patient who is symptomatic and in a high degree block, it's appropriate to go to immediate pacing, but just be aware if you're going to pace somebody, you probably need a line. If you need because you also need to sedate. So while you're getting the pacer set up, it's reasonable to try a dose of atropine while you're setting up the pacer to see if that works. And then if it doesn't work, go right to transcutaneous pacing. And pacing, again, all of the monitors are set up. You start at 60 milliamps and 60 beats per minute. The monitors are preset for that because most people need to go up to 60 to capture. And what we've noticed was it was taking people way too long to ramp up. So we just set all the monitors. So it's 60 and 60. And then you go up by milliamps until you get capture, electrical capture. Once you get electrical capture, then you feel for mechanical capture. If you have consistent electrical capture and no mechanical, if you have consistent electrical capture, raising the milliamperage won't improve your mechanical capture. What is probably happening is that you need to get more pressure. You may have capture, you just can't appreciate a pulse. So you can do one of three things or three things concurrently. Number one, increase your rate, right? If your rate is too slow, cardiac output is a function of stroke volume and heart rate. So increase by 10 or 20 points and get your heart rate up to 80 and see if that improves your cardiac output. If that doesn't work, open up those fluids wide, and frankly, your fluids should be running anyway because you want to make sure that they're not hypotensive. So if your heart rate is 80 and your and you've given them a good fluid bolus, then they probably need to be pressed. All right, so bear that in mind. If you're trying to get mechanical capture, it's just like PEA. You've got the electricity, now you got to figure out why you don't have any squeeze. All right, so you go to medical control for norepi, dopa, epi infusion, glucagon, maybe if they're very slow, maybe they're beta blocker overdose, and that's why it's not working. Maybe they have a calcium channel blocker overdose. That's why it's not working. So all of those things are your H's and T's that you should think about to try and get mechanical squeeze. Okay, questions on that? Okay, bradycardia, just remember for kids, the first drug of choice is epi. For adults, it's pacing and atropine. For kids, it's epi. Note the drug dosing. It's a little bit different. 0.01 milligrams per kilogram. Okay, and that's 0.01 milligrams per kilogram of the cardiac dose. That's 1 to 10,000, not the 1 to 1,000. Right? So keep that in mind. The maximum dose is 0.5 milligrams of the 1/10,000 solution. Or you can give atropine 0.02 mg. And these are usually, atropine is usually for kids with much higher increased vagal tone or AV block. And then, of course, if that doesn't work, then you go to pacing. With kids, it's epi infusion, 0.01 to 0.03 mg per kg. And again, these are on pumps. These have to be on pumps. All right. Or you can do 0.1. I'm sorry. Epi IV is 0.01 to 0.03 mg per kg. And that's a single isolated bolus. Right. If you then go to the infusion, it's 0.1 to 1 mic per kilo per minute. Questions on that? Okay. I realize we're at 8 o'clock and we had this exact same problem at the day session. There's simply too much information to go through. I'm happy to continue moving on, going through the protocols if you guys want me to, and I'll stay and do it. If not, I completely respect that you want to, you want to go back to your life. Do you want to take a 5-minute stretch or you want me to keep going? You guys good? All right. Okay. I mean, look, honestly, if you need a stretch, just get up and walk around and stretch. That's fine. I'm just going to keep roll through. Okay. Asystole and pulseless electrical activity, the most important thing with PEA is and asystole for that matter is reversible causes. Why is this person who has electrical activity not having any squeeze? So standing orders is epi, and of course calcium chloride in case they're hyperkalemic. It's 20 milligrams per kilogram IV or IO to a total of 1 gram. Everybody just gives 1 gram in cardiac arrest. There's no question about it. And then be thinking, what are my reversible causes? Bicarb, atropine. Are they too hot? Are they too cold? Is their sugar okay? Again, is it a beta blocker? Do they need glucagon? If you've already given the calcium because you've ruled out hyper-K, that'll take care of a calcium channel blocker overdose. Do I think they're cocaine overdose? Do I think they're having a massive MI, which frankly, there isn't a whole lot for that. Either they're going to have pulses back or they're not. We can't do that much for it, but you can watch for the ST elevations. Of course, always fluid, at least 250 to 500 cc's should move the needle a little bit. You want to be careful not to fluid overload them, but if they don't have a pulse, it's a Hail Mary. So go ahead and give them at least 250 fluid bolus. If there's any sign of trauma, always consider tension pneumos. If they have a history of asthma, always consider, do they have hyperinflations? And again, how do you know that? You listen for the ambu bag. You listen, is there air movement? If you don't see any air movement, needle decompress them. If you have a PEA and you have no squeeze, consider needle decompression or for tension pneumo. Pediatrics, same exact thing, except it's more likely that they are going to come back with epi. But again, explainable causes. Epi, and here's the interesting, for kids that are in PEA, they say standing orders, you can do an epi infusion. We don't do epi infusions for adults. Notice here's epi adults. 1 milligram IV or IO, but we don't put them on an infusion until we get ROSC. With kids, they do say you can go ahead and try an infusion, and this may be because kids respond so well to epinephrine. So that you can use that as a ditch effort. I also think we tend to terminate PEAs more in adults. We are not supposed to terminate PEAs in kids, nor do most of us consider doing that. So that might be another reason why it's standing order epi infusion. And of course, you can always ask for bicarb and atropine, all the while thinking of your H's and your T's and what can I ask medical control to reverse it. VF and VT, pulseless is pretty straightforward. It's defibrillation, epi, amio, and then if you think, again, explainable cause, are they in VT because of hypomagnesemia? Are they in torsades? Are they in DTs? DTs will cause hypomagnesemia. Are they eclamptic? If you think that they have a sodium channelopathy, like we talked about, cocaine overdose or TCA overdose, bicarb is the name of the game. That will be the way to treat their VT. Amiodarone is the primary drug. We start with 300. If they remain in arrest, you can go ahead and repeat with 150. If they come out of arrest, then it's medical control. And then, of course, medical control. Now, I can tell you, and I'm pretty sure that I saw this in the new updated protocols. Amio and lidocaine will be standing orders. So yes, you need to ask for medical control for this now. I am unlikely to ask you that question because I think it's going to change. So the important thing that we want you to be thinking about is, why is this person in refractory VT, right? So primary treatment is defibrillation. Convert that rhythm into coordinated squeeze, coordinated beat. And then once you convert it, epinephrine and amio, or epinephrine and mag. If you can't convert it, rather, I'm sorry. That's pulseless VT. Pediatric, it's similar, except that epi comes first although epi comes first with adults too, so it doesn't much matter. Amio, the only difference is amio, the dose changes. For adults, it's 300 milligrams. For kids, it's 5 mgs per kg. With adults, you're defibrillating at 360. According to statewide treatment protocol, you do high quality CPR and defibrillate at the recommended guidelines for your monitor. Ours is 2, 3, and 360, but Dr. Dyer has said we in our system automatically defibrillate at 360. Notice there isn't actually a setting here because every defibrillator is a little bit different. However, for kids, we always charge and defibrillate at 2 joules per kilo to start, and then we move up to 4 joules per kilo to a maximum of 10. So we defibrillate at 2, then we do it 4, then we do it 10. If they remain in refractory VF, it's pretty rare, but it does happen. Epi 0.01 mg per kg. Again, this is the cardiac dosing as opposed to the 1/1000 that we've been talking about for bronchospasm and anaphylaxis. This is 1/1000, the 10 cc Bristojet. If you haven't seen it or you're a little confused, what do you mean by cardiac versus check and inject? Come in to the ALS skills lab, and I will show you the difference in the dosing. And then if you still can't break them and they remain in pulseless VT or VF, defibrillation doesn't work, epi doesn't work, amio doesn't work, think H's and T's. What could be causing this? Early contact with medical control, and they will help you kind of work through that. Okay, so that takes care of the tachydysrhythmias. Congestive heart failure, I hope most of you guys are pretty savvy with this. We've had BLS CPAP for quite a while. Nitroglycerin and CPAP are the name of the game. You want to open up those vessels. You want to venodilate them aggressively and then get them on CPAP, and that really is a game changer. So get them on, get them up. If they're acutely hypertensive, we have 6.17, which is IV nitro. I don't think I'm going to test you on this, but this has been protocol for a couple of years now. It is standard protocol across the Commonwealth, so you really should know it. We will teach it aggressively when we teach you the pumps. The important thing to know is really, if your patient has a blood pressure of greater than 160, you can put them on an IV infusion pump starting at 100 mics a minute. Okay? So really what makes this so valuable is you don't have to keep breaking the CPAP seal to squirt them with nitro. So some people used nitro paste, but it didn't really work that great. It was very slow acting. And people that had pressures of 220, 240, 250, had plenty of, we got to venodilate them. They needed much, much more aggressive pressure management. And the way to do that is to put them on IV nitro. So if their pressures are very high and it has to be above 160, then they can go on an IV pump. They start at 100. Now, if their pressures are only 120 or 130 and they're in failure, you still can give them nitro. You just give them sublingual. You don't put them on a drip. If they present to you and they haven't gotten any nitro before you get to them, you can elect to hold off on giving them sublingual, just get them on the CPAP. And then when you put them on the IV infusion, you can give them a 400 microgram IV bolus of nitro. And then after the bolus, which is over 1 or 2 minutes, is a bolus they get, then they go on 100 mics per minute. Okay. It is really, really very, very helpful. It's standard of care now with nitro infusions. You can increase that nitro by 25 micrograms every 3 to 5 minutes. You check their pressure. If their pressure is holding, you can bump that nitro infusion up by 25 mics per minute. So 100, 125, 150, 175, 200. And you can continue to increase the dose as long as their pressure holds above 160 to a max of 300 mics per minute. Okay? If their pressure starts at 250 and then, you kind of move them up to, you're bumping them up and they get 200 and then their pressure comes down to like 140, you let them sit at 140. You let them sit at that whatever 200 mics, 175 mics, and just watch them. As long as their pressure doesn't keep dropping, that's where you want them to level out. You continue to raise their nitro dosing until what's the trigger for we've reached therapeutic levels is reduction of dyspnea. So the whole goal is reduction of symptoms, right? When we put somebody on a CPAP mask and we spray nitro, the goal is to get them breathing better, slowing down, speaking in full sentences, being able to breathe, right? Now, obviously, their RALs drop because we venodilate them, and osmotically, the fluid goes from the lungs back into the vessels. But if you'll notice, patient success is dictated by resolution of symptoms. So if you get up to 175 micrograms and the patient looks better, feels better, is talking better, even if their pressure is still 200 over 100, if they look good and they feel good, that's where you stop. Okay, so the resolution of symptoms is what stops your increase. If they start to have trouble breathing again, then you can raise it again. But again, it starts at 100. You move it in 25 mic aliquots to a max dose of 300 or resolution of symptoms, and then off you toddle to the hospital. Now, of course, if your patient is acutely short of breath and their pressure is below 160, you want to get them on a nitro drip. You can, if they've got really bad ejection fraction, right? So, I mean, these are patients that might be flirting with some early cardiogenic shock. You certainly don't want to put somebody on nitro if they're in cardiogenic shock. The point of that is that they're hypotensive. But if somebody who has poor ejection fraction might be in congestive heart failure with a pressure of 120 or 130, and maybe 50 mics of IV infusion nitro will help them and not drop their pressure too much. But all of that is medical control. Okay, so it says if the patient has a systolic blood pressure 120 to 160, but their respiratory distress is severe, their SATs are low, they're clearly in failure, then you can start a continuous IV infusion at 50 mics a minute, which is a much lower dose, but must be medical control. Okay, questions on that? It's not a hard protocol, but it's an important one, and one, honestly, that we use a lot. Okay, let's go back to ACS. I'm pretty sure, did we? Yeah, we don't need that. We don't need that. Okay, so we've talked about MI, nitro, standard. Oh, these are all your, yeah, sorry, I lost my place here. Okay. We are now into Targeted temperature management, we don't really do here at our system. The important thing to remember is when managing a critical care patient, you want to try and keep them as normal to the baseline as possible. So you want to keep their end titles within 35 to 40. You want to try and keep them normothermic, 96 to 98. You want to try and keep their SATs 95 to 99. It's all about normal, normal, normal. So just keep that in mind. Post-resuscitative care, this is important and is a little bit of a veering off of the protocols that we talked about with shock. Remember, we said all shock, you need to talk to medical control to put them on a pressor drip, except anaphylaxis. And here's the second one. So if you have a patient who you've just brought back from cardiac arrest and you have post-resuscitative care, understanding orders, you can put them on a norepi drip. Standing orders. So obviously you get them back, you give them a fluid bolus. Always give somebody a fluid bolus. Sorry. You have the option of DOPA, but honestly, DOPA is a messy, sloppy drug. It gives you a lot of different things for a lot of different causes. We should only be using it if we don't have access to a pump. Norepinephrine is a better, pure alpha drug, which will improve your blood pressures with less other side effects. Pediatric, also standing orders. Again, this is post resuscitation. That's your kind of get out of jail free card. Your patient's really critically ill and you can't get their pressures up with just fluid. You can either start them on a norepi drip, or for peds, you can choose an epi drip. But honestly, just remember norepi, 0.1 to 0.5 mics per kilo per minute, and then titrate to a systolic blood pressure. Now, interestingly, they have a systolic blood pressure of 90 for both adults and PD. Ideally, if you're really elegant in your medicine, you should be titrating to the blood pressure of the pediatric patient that you're working with, right? So, but that's just something to be aware of. And then, of course, post-resuscitative care, if you've had a patient who's come back from VF or VT, or who's throwing a lot of ectopy, consider possibly amio or lido as a medical control option after you've got ROSC back. Okay, so if you'll notice, for those in the audience who've had a ticket a while, no longer is amio and lido standard operating procedure for post VFVT. If they're no longer in that rhythm, then you got to kind of talk to medical control before you treat for it. Okay? Any questions on that? That's important. We do that a lot. So you need to understand that. Okay. SVT, the easy part is again, think about this. Why is it doing that? It's really irritating. When you are in your practical exam and you're doing your static cardiogram, or even when you're doing your mega code, they should be giving you what the patient vital signs are. But in your static, and they're just handing you a strip, the thing that you want to always ask yourself is stable or unstable. So if you have a patient who's stable, you're looking at Valsalva maneuvers and medication, right? And what predicts stability? Mental status, blood pressure, physical symptoms, palpitations, diaphoresis, that kind of thing. If your patient is stable, I've always used mental status as the cardinal yardstick for stability. If my patient is alert and talking, I have time to start a line and give meds. If my patient is obtunded and not responding to me, I'm going to quickly move to cardioversion. If the systolic blood pressure, according to the state protocols, if the systolic blood pressure is less than 100, that is unstable. Okay, so you can use that as if my patient is hypotensive, as defined in the statewide treatment protocols by a blood pressure of less than 100, then you are well within good clinical care to cardiovert. Now, if cardioversion is warranted, remember it says treat sedation, analgesia for electrical therapy. So you got to consider, yeah, I'm going to start an IV, I'm going to sedate my patient, and then I'm going to cardivert them. For SVT, you start at 50 joules. Okay? So to recap, for AF, we start at 200. For a flutter, we start at 100. For SVT, we start at 50. And if I'm being honest with you, ultimately it doesn't really matter as long as you know you're cardioverting and not defibrillating. That's the more important point. Okay? Always go higher rather than lower. Higher is better. So if you can't remember, is this 150 or 100? Go to the 100 mark. Because
Actually, Sue Flutter is 50.
a flutter is 52. Ah, okay. So there you
Yeah.
go. So right. So I apologize if I'm confusing that with protocols that are changing come June. But the reality is, if you'll notice, with all of these therapies, if 50 doesn't work, you go to 100, right? So if you think about it, you're not harming the patient by going right to 100. I'm not saying you should do that. I'm saying nobody's going to fail if they're going to cardiovert at 100 and it should have been at 50. Because that's not bad medicine. You're just going to a little bit higher dosing than you should. What you might have happen is if you defibrillate instead of cardiovert and then your patient VFs. And that's more problematic. Okay, so just keep that at the forefront. Thank you for But was I right about AFib? AFib is 200. Is that right? So AFib is
Yes,
200.
that is correct.
Okay,
Yes.
so maybe the way to remember it is narrow, tight rhythms with a pulse. You start at 50, but the irregular rhythm, because AFib is much harder to break, so that's why they go to 200. Okay, and again, so it's a sedation and a cardioversion. However, if your patient is stable, again, as defined by a good blood pressure, good mentation, it's 6, 12, and 12. And just be aware this drug acts very, very quickly, is very fast on and off. So you want to go as proximal as you can in the circuit. This is the time to do an AC line if you can. And follow with a good 20 cc flush. If none of these drugs work, if your patient or maybe your patient is stable but adenosin's not working, or you're slowing it down, you see flutter waves, and you're like, I need a longer acting agent, I then medical control for DILT or amio, which is appropriate if that's what you think the patient needs. And again, Wolf Parkinson White, you want to be really, really careful with adenosine, because if you have a patient who has a reentry tachydysrhythmia, and then you block that reentry node, you cut off the AV node, you can in fact precipitate VF. So amiodarone might be, if your patient has a history of WPW, if you don't know, you don't know, but if you know, or your QRS is a little bit wide, or you think maybe you've got a delta wave that you're looking at, then you really, really should be on medical control getting orders for amio. All right, that's not a drug you want to give adenosine to. Questions on that? Good. Okay, pediatric, it's the same exact thing. All that changes is your dosing. So your order works the same. Cardioversion is 0.5 joules per kilo, up to a max of 2 joules. Same as the other cardioversion rates that you have. Of course, always be mindful of sedation, especially in kids. And adenosine is 0.1 mg per kg. And then you increase to 0.2 to a max of 12 milligrams for the second dose. Okay. So figure out the dosing mg per kg, and then it's either 6 or 12 as a maximum. Okay. Now, interestingly, I think it's worth reading this. And remember how I said I had that 7-day-old with in vitro WPW I knew, and her heart rate's 240, and we kind of sat on her. I put a line in her, and we just watched because kids' heart rates tend to be faster no matter what. Synchronized cardioversion should be considered for only those whose heart rate is in excess of 220. And even then, they should have signs of hypoperfusion, as defined by decreased LOC, weak thready pulses, prolonged cap refills, no palpable blood pressure. So really, 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 you want to be 100% certain that these kids are acutely symptomatic before you light them up. All right. Vagal maneuvers may precipitate asystole, should be employed with caution. And honestly, any of this should always be done under the protection of cardiac monitoring. Always, always, always. Okay, so VT with pulses. We talk a lot about this. Now we're getting into the kind of, is it VT? Is it SVT? The good news is if they're stable, just go with meds. Amiodarone will work for both SVT and VT. So if they're stable, you can go ahead with a 150. Understanding orders, it can be 150 of amiodarone. If they are unstable, then it's cardioversion. For adults, it starts at 100. And for peds, it's still the same, 0.5 up to a max of 2. So it's actually easy to remember because we have to remember all these different doses for adults, but for kids, it's just cardioversion is 0.5 joules per kilo. Again, always being mindful of sedation, okay? If you're not sure or if the amio doesn't work, then always medical control, consider magnesium, amio infusion, lidocaine, adenosine, bicarb, any of these for a wide complex TAC that will not break, but it's all under medical control. Okay. Any questions on that? Okay, let's quickly go through burns. And finally, Benny's getting to stuff that he's not seen at all before. It's important to recognize that point of entry is important. Anybody with a burn injury greater than 20% gets a 500 cc fluid bolus. And that's anybody with greater than 20%. That's not first degree. First degree doesn't count. Interestingly, how they talk about first degree here, we don't, it's really anything that's not superficial. But partial thickness gets 500 mLs for adults and 10 mLs per kilo for peds. We don't have transport times greater than an hour, so I wouldn't worry about that. Pain management, of course, we already talked about multiple times, either fentanyl or ketamine. Personally, I think for this patient population, I would go with fentanyl because burns are incredibly painful and can trigger emergence reactions. Just give them an opioid, right? These kids will get, and these are the ones that you're going to kind of redose every 15, 20 minutes. You might be giving 50 microgram aliquots. So I answered my own question. I wasn't sure. Hydroxycobalamin is in fact standing order. So this is the cyanide antidote that we carry is hydroxycobalamin. If somebody, leaves a note saying, I took cyanide, then it's technically medical control. But if you're bringing them out because of burns and you suspect hydrocarbon emission and CO poisoning, then you can go ahead and it's 5 grams over 15 minutes or 70 milligrams per kilogram for kids. Here's your rule of nines if you want to kind of refresh. You can also use 1% of the palmar surface, whatever you're more comfortable with. But just get a general sense because anything more than 10% body surface area, or including head, hands, feet, genitalia, over the joints, should get transport to the burn center. Any questions on that? It's pretty straightforward. It's burn, it's just, sterile dressings and pain management. Okay, drownings, it's all supportive care and manage hypothermia and any cardiac instability that you get. I will say, um, they're not dead until they're warm and dead. So if somebody's been submerged 20, 30, 40 minutes, especially if it's a child, pull it up and work it. Don't feel stupid working it. The only people that we shouldn't be working that we're pulling out of our waters here, which are always cold water drownings, are somebody that has frank decomposition. Eye injuries, we don't really have to go into that. You're not going to be tested on eye injuries. Head injuries, the important thing to remember about head trauma is avoid hypotension, aggressively avoid hypotension, hyperventilation, and hypoxemia. And the way we do that is good, high quality BLS field management of the airway. And the reason I say BLS field management of the airway is because too many of our folks are too quick to try an RSI or MAI, a traumatic brain injury, because these guys can be challenging. But if they're not appropriately resuscitated, we give these drugs that we carry and we drop their pressures. And have we really done them any favors? So I want you to aggressively think about, do I need to take this airway? What is my SpO2? What is my end tidal? And here it is defined as less than 95% is not adequate oxygenation. More than 95% is adequate oxygenation. Is their end tidals good? Are they breathing effectively? Are they Kussmaul respirations? Are they chain stoking? Of course, if you have somebody who is showing signs of Cushing's reflex, that is, they are becoming hypertensive and bradycardic. Okay, now you're up against a wall, and now you're looking at somebody who is potentially herniating, and there is some value in getting control of that advanced airway and ventilating them to an end tidal of 30. And that's where we want to live. But again, that's only if your patient is actively herniating in front of you. If they're actively herniating and they are a pediatric patient, in patients younger than 15, then we are standing orders for 3% hypertonic saline, and that is 3 mLs per kilo to a max of 250 over 20 minutes. But again, that's only if we have signs of herniation, and it's only in the pediatric population. If you want to do it in the adult population, it is standing order. Standard shock trauma, always be mindful. We do not routinely give fluid resuscitation for patients who are hypotensive. We look specifically to altered mental status. We operate under permissive hypotension because we want any clots that are formed, we want them to continue to hold. It's only if somebody becomes obtunded, hypoxic, confused, disoriented, unresponsive, that we then go ahead and we resuscitate with fluid. And of course, tranexamic acid. And TXA in our system is, where is TXA? 6.4. Yeah, there it is. It is 1 gram over 10 minutes. Most people, it says 15 milligrams per kilogram, but honestly, everybody just gives a gram. And I don't think that they hang it. I think they just push it slowly. So that's basically to stop bleeding. If you have a stroke index, and again, I know that a whole bunch of you didn't know what stroke index was. Stroke index, again, is your systolic blood pressure divided by your heart rate. So if your heart rate is higher than your BP, your systolic BP, your stroke index is greater than 1, and that is a poor predictor of outcome. You want a low stroke index. So if your stroke index is greater than 0.9, you are probably going to trigger massive transfusion protocols. It is a guide for,
Shock index,
again,
right, Deputy?
say again?
Shock index, not stroke index.
Shock index. I'm sorry, did I say stroke index? I apologize. I mean, I've been doing this too long too. Yes, shock index. You're absolutely right. Shock index. Any shock index greater than 0.9 is a predictor of massive circulatory collapse. You definitely want to get TXA on those folks. Okay, so that's sorry. I keep bouncing back and forth between the protocols here. Oh, whoops, that's 6.2. Come on. We're almost done, guys. Almost done. All right. Okay, we did head trauma. We did multi-system trauma. Musculoskeletal is pretty much the same. It's, splinting. Soft tissue and crush injuries. Be aware that crush injury makes you more susceptible to both compartment syndrome and a condition known as rhabdomyolysis. If you don't know what that is, you should look it up. Rhabdo makes you more susceptible to hyper K. It's one of those things that we are concerned about. It's why we want anybody who's trapped or lying, the elderly person who's found lying on the ground for 12 hours. Those are patients that should be monitored for cardiac instability and managed appropriately. Spinal cord injury, you guys are the experts on that. I don't need to go through that with you. If you want me to go through it, let me know. But honestly, that's pretty much BLS level care, and you're all quite proficient in that. Traumatic cardiac arrest. I think the important takeaway from traumatic cardiac arrest is that if the patient is in arrest when you arrive from blunt traumatic arrest, and you're certain it is a result of blunt trauma, then you can go down the algorithm for rationale for not initiating care. But you have to be certain, and we can go over that. And it is kind of important. You have to be certain that it is a result of blunt trauma. If there's any question that it's not a result of blunt trauma, you got the person who's in the MVC who is in cardiac arrest behind the wheel, but they don't look like they've got a lot of trauma. I think everybody agrees that's you pull them out, you work them, because it might have been the arrest before the trauma versus the trauma to the arrest. Likewise, if you have somebody who has penetrating trauma, the protocol says if you are within 15 minutes of definitive care and it's to the cardiac window, you then transport. I will say that we've had a couple of very high profile saves from penetrating trauma that was pretty far out, and we were still able to resuscitate. So I personally, as a caregiver, have altered the way in which I look at this for Boston. I think that if the patient has isolated penetrating trauma, they have one or two bullet holes, then I think it's worthwhile rapid transport to a trauma center to attempt possible resuscitation and up to the OR. If, on the other hand, the person has 10 gunshot wounds to the belly, the chest, the head, okay, that's a different story. All right. Obvious signs of death include, decapitation, 100% incineration, transection of the torso, obvious destruction of the brain or the heart. These kinds of things, if you see, then of course we don't work them. But I think one bullet to the chest, even if you're in Hyde Park, give the guy a shot. Is he likely to live? If he presents, again, if he presents in cardiac arrest on scene, he's probably not going to live. But I have had a couple of, I don't want to say recent, but a couple of instances in the past, 3 or 4 years where they were in cardiac arrest. It was one was a gunshot wound to the leg, one was a gunshot wound to the belly, and they did resuscitate, and then the patient did live. So I think we might have been a little bit quick to say these, penetrating cardiac traumatic arrest is non-survivable in the austere environment. I'm not so sure that's it. Okay, upper airway obstruction, we're not going to get into surgical airway here because that's something you will learn in the internship if you get into it. So I'm not going to ask you questions on that. I do think, however, you should absolutely know how to evaluate an airway based on a Mallampati score. So look at difficult airway and look at how you assess an airway, because this is really important when you assess the degree of severity of maybe anaphylaxis or burn danger. So look at that. How do you assess an airway? And then, we will get into how you actually take that airway and address a difficult airway that you can't intubate. It's called CECO. Can't intubate, can't oxygenate. But there won't be any questions directly on the exam directed at that for your sake. So you don't have to worry about that. Medical director options. Well, you already know BLS. You don't need that. I told you we're not going to talk about needle cracks. We're not going to talk about urban search and rescue. There will be no questions on that because not everybody is USAR. I'm curious, are you guys all USAR trained? I know Michelle is. Andrew, you're not. Benny, are you USAR trained yet? Okay, all right. So I'm not. We have time to do that. TXA we've talked about. Check and inject, you guys know. Of course, know all the drugs that we carry. Okay, withholding cessation of know the drugs that we carry because any drug that is currently in our drug box is fair game, except I will not ask you questions on automidate. I will not ask you questions on rocuronium. Those are the RSI drugs. I will not ask you questions on that. Nor will I ask you a question about RSI as regards ketamine. So if there's a ketamine question, it'll be as it regards to anesthesia or procedural sedation for pacing, something that you would already have to do. Okay. Anybody have any questions? Has anybody read the withholding and cessation of resuscitation by paramedics? Have you guys read this? Okay. Okay. Here's, I think, what we're going to do because it's already 9 o'clock. It's 10 to 9. We're already, it's just no way to get through all of these protocols. We're going to stop here. I am going to take 10 or 15 minutes tomorrow because we have Teaching Tuesday tomorrow. Our last Teaching Tuesday is tomorrow evening at 7 o'clock. I will take 10 or 15 minutes to go over withholding initiation of resuscitation, which is kind of like what we're talking about a little bit about, you come upon a cardiac arrest. Does this qualify? And cessation of resuscitation by medics, right? You're the guys in there doing the cardiac arrest. When do we decide that this is not reversible? And we're going to talk with the family about termination. It's actually a big topic. We could spend an hour. I've done an hour on it in the paramedic internship, and we'll certainly do more. But I think for your sake, for the exam purposes, it's what does the protocol say about when we can withhold. And I know all of you routinely do non-viable, so hopefully none of this will be new. But that's pretty much it. Anything that we went over today, I'm just kind of sliding down. Anything we went over that might have been a little confusing to anyone? No? Okay, great. You guys did a fantastic job hanging in there. Thank you, Benny. You get MVP for being here not once, but twice. I am going to let me stop recording. First of all, let me stop sharing because you don't need to look at this anymore. Okay. Oh, look at that. I never started recording the second half. So you guys uh stop recording. Okay.